Okay, here is your stem.
Okay, ma'am.
Okay.
Is any other slide?
Just one slide. So if you've read and understood, considering it communication skills station, please begin.
Hi, my name is Ofyong. I'm one of the surgical doctors. I'm calling to speak with the hepatobiliary consultant to refer to him a case. Can I confirm that I'm speaking with the hepatobiliary consultant?
Yes, speaking. Please summarize your case.
Okay. The patient is a 44-year-old female who had a cholecystectomy 4 days ago, but currently having worsening abdominal pain and nausea. Clinically, the patient is tachycardic and jaundice with abdominal pain. And the available investigation showed that the CRP is high, bilirubin is high, and the white cell count too is high. And the available image in an ultrasound, it showed that there is free fluid in the abdomen. And I'm calling because there are concerns that there could be injury or bile leakage, and this patient will need urgent intervention.
All right. When were the blood labs taken?
Unfortunately, I'm very sorry. The investigations were done 2 days ago, but as soon as we are done with this call, I'll go back and repeat the investigations again.
So you said patient has CRP, which is 50. Do you think patient is having infection?
Yes, the elevated CRP can be due to an infection, but also as a result of a response to surgery, there can be elevated CRP. But in that case, the CRP will be decreasing by the day, but this seems to still be high, so it can be likely due to an infection.
Okay, what do you think might be the provisional diagnosis? What is patient going through?
Okay, this is likely a bile leakage due to uh, injury to the stump or like leakage from the cystic duct stump, which can be as a result of slippage of the clip and also due to increase intraductal pressure due to retained common bile duct stone. It can also be due to direct injury to the common bile duct or bile leakage from the hepatic bed or due to a duodenal injury.
All right. So ultrasound was done or not, and what does it show?
Yes, the ultrasound was done and it showed free fluid in the abdomen, but the common bile duct was not dilated.
All
It
right.
didn't show any dilation.
Does the patient has drain in it?
Yes, there's bile in the drain.
Yes. How much is the bile and what is the color?
Okay, it's about 100 mils and it's green.
Okay. And what do you think? How you should be managing this patient?
Oh, okay. First of all, this is a critically ill surgical patient, so I'll first of all resuscitate the patient. I'll ensure the patient is fluid resuscitation, and then I'll give IV antibiotics, and then I'll repeat the investigations again, which will include a full blood count, the CRP, the LFT, and E and U. And then once the patient is stable after resuscitation, I'll consider doing an endoscopic retrograde cholangiopancreatography to first of all delineate where the injury is in the hepatobiliary duct, and then consider repairing it or putting a stent. But unfortunately, we don't have ERCP currently in our facility, and that's why I want to refer the patient to you.
So why do you think patient would need ERCP and not MRCP?
Okay, because ERCP is diagnostic and is also therapeutic. So it can help us delineate where the injury likely is, and also help us in also placing a stent. Unlike MRCP that might just give us where or show us where the problem is, but it may not be therapeutic.
All right. Can you tell me if you could arrange ERCP to confirm the source of the bile leakage in
Okay.
your localities or in your premises?
Okay. If we have an ERCP, so it's an X-ray that is taken to study the hepatobiliary system. So it involves putting a telescopic device through the esophagus, through the stomach, and then the duodenum, and then through the ampulla of Vata, and then a dye is injected, and this dye moves through the hepatobiliary duct, and then we can see it through the X-ray.
Dyes, if you could just tell me, dyes injected through where?
Is injected through the ampulla of
Better.
Vata.
Yes, very good. Do not
Okay.
confuse yourself. Okay. And then a bile leakage will be shown how?
Okay, it will show that the bile is leaking into the abdominal cavity.
Yes,
So, and that
through
will be seen next.
extravasation of the dye. All
Yes,
right.
it's
Please tell me if there is no bed available at my end, how would you go about and how would you manage your patient?
okay. First of all, I'll speak with the bed manager and explain to him the urgency of my case currently, and I'll also speak with him uh, to facilitate the discharge of clinically stable patients. And while waiting for him to do that, I'll continue with the resuscitation of my patient. And then as soon as there's a bed space, then I'll arrange for the transfer to be done.
Okay. Can you confirm for me if your patient is suffering with biliary peritonitis?
Okay, yes, the patient can be suffering from biliary peritonitis because the bile leakage can spill into the abdominal cavity. And currently, the CRP is elevated, which is an inflammatory marker, and patient is tachycardic, and so it can be biliary peritonitis.
All right. So normally, what are the places from where a bile can leak?
Okay, it can leak from the cystic duct stump. It
Okay.
can leak from an accessory cystic duct.
Yes.
It can also leak from the common bile duct if there's an injury, direct injury to the common bile duct. It can also leak from the liver bed
Yes.
or when there's a case of a duodenal injury. Since the
Um,
ampulla of Vata, the bile enters through there. So injury to the duodenum too can cause biliary leakage.
okay. One last question. Tell me, why is it urgent
Okay,
that you're
it's
calling
urgent.
me right now?
Okay, it's urgent because my patient can be having biliary peritonitis due to the bile leakage, and this will need an urgent intervention for the repair of the source of the leakage.
When do you plan to remove the drain of your patient?
I will not remove the drain for now until I'll continue resuscitation because they just so that I'll be able to monitor the extent of the leakage until I'm able to successfully transfer the patient.
And until
And
after
and the,
ERCP and stent is given,
okay,
and
okay,
then there is no more than 200 ml of fluid in the drain per day.
okay,
Okay.
thank you.
And there is
200.
no peritonitis. Then you'll
Oh,
then you'll remove it after confirming it with ultrasound. Good.
okay, okay.
Thank you.
I didn't see that. Thank you very much.